I want to get right into the conversation because there's a lot of discussion to have here. As we have Dr. Sachin Jain and Dr. Ronald Wyatt. Thank you for joining us today and being available to talk to us about this paper, the meaning of the paper, the genesis of the paper, and so forth. But before we get into that, I'd really like to start off with hearing a little bit about you and your journey to this place that you are in health equity. You know, many of us have a story where there was that aha moment in our lives of what direction our lives would take. So, Sachin, I'm going to start with you, and then we'll go to Ron.
Well, thanks so much, Pam. It's a real honor to be here, and especially to share the stage with Ron, who I've really come to admire over the last couple of years of knowing him. You know, my story really just begins as the son of immigrants growing up in northern New Jersey, and just realizing that racism was just a part of my everyday life and existence as a young person. I was growing up in the 80s and in a largely homogenous community, and I was otherized. I was the vegetarian kid at the lunch table. I was you know, the only person of color in my community. And you know, it left an indelible impression upon me that I was not included with the in-group. Subsequently ended up you know, attending Ivy League, you know, undergrad, medical school, residency, business school, and then was the subject of a racist attack of a patient on the wards. And you know, I think I'd forgotten about my childhood struggles until I was kind of brought back to that moment where I realized, wow, we really live in a world where people do judge each other by the color of their skin, even if they say that they don't. And then, you know, kind of working in corporations that are focused on healthcare, you know, with a lot of talk about health inequities and a lot of talk about, you know, some of the challenges that people of color face in this country, but then also not seeing a ton of action. And so I've really devoted a significant portion of my leadership of, you know, the SCAM group and health plan to really trying to drive more health equity, to reduce disparities, and to move away from really just talking about it, having it be what Ron calls a hustle, because I really do believe that's just a great term for it these days. You know, we've got health equity officers, institutes, centers, but very little real action. And so, you know, my orientation is to try to drive as much action as I can. I think this paper that we wrote is a call to action, but the real work ahead is actually the action.
And accountability.
Absolutely. Absolutely.
Thank you, Sachin. Ron?
Yeah, so thank you again. Likewise, an honor to be here with all of you and the people on the call who took the time out of your day on a Friday to be with us. So I am from Alabama. I'm in Alabama. I was born in Selma, Alabama, and grew up in what's Black Belt, which remains one of the most impoverished areas, not just in the United States, but the world. But I grew up with people who valued education. I grew up with people in a segregated South where we had segregated waiting rooms at clinics to understand that we could always do better. Somewhere around my late adolescence, a story came to us in the Black Belt in Alabama of a single mother, Black mother, who took her child to a general practitioner there near where we lived. The child had a laceration. The general practitioner placed sutures, and once that Black mother said that she couldn't pay, or she could pay, as we say, along the way, the sutures were removed by that general practitioner. The mother then took that child to a veterinarian nearby who put those sutures back in. I had, in fact, a white science teacher around that time who said to me, "You have an aptitude, you should think about going into medicine." So combine those two that led me on this journey to medicine. I was told I would never go to medical school. I was told to never even think about being pre-med at the University of Alabama. Ultimately, after 3 attempts, got into medical school and graduated from the University of Alabama, Birmingham, became the first Black chief resident at St. Louis University, oldest medical school west of the Mississippi River. On the day that I became chief resident, an attending physician said to me, "My father said we would never have a Negro chief resident at St. Louis University." And so that led me on this path to say, you know, we can always do better and make a difference in the lives of people. So that has led me on this journey since then, and being in the middle of, what I call the belly of the beast of inequities, every place I've been, to see those differences in outcome, the loss of trust by populations that have been marginalized and oppressed for all those years. So at one point I said, okay, I have the skills and knowledge and competence, but there's something bigger here that we can do to improve the lives of everyone. So that brought me to looking at what can we do around disparity and equity, and just had the great opportunity to work with some wonderful leaders every place I've been, especially at the Joint Commission, where people took an interest in disparity and equity. And as we say, one of my leaders there said, I'm going to keep this on life support. So it's not just me, other people that believe that we could do this. And here we are at this moment in time that I think makes the people that I came from in Alabama proud, that we can come together and have these conversations. And I'll just close by saying it because my great-great-grandfather was enslaved. I don't think he or my great-great-grandmother could have ever imagined having a conversation like this and not being hung. I'm just going to say it. So I stand on their shoulders. They got me here, and it's an obligation for me and all of us, back to Sasha's point, is to do more than talk about it, but to act on it. And to your point, to then say, we are all accountable for what we do and how we improve lives of all people.
Absolutely. And Sachin, you started talking about the hustle, which we also got from Ron. And I have another Ronism. People love to admire a problem. So all of us who have been in the work of health equity and the diversity, equity, inclusion work, you keep on hearing, well, let's research this, let's research that, let's look at that, let's look at this. And you think, well, at some point you got to do something about it. Now, that's not to say something's not been done, that things aren't happening out here, but this paper really gets to what are the things that folks are seeing, what are the things that are working. So let's spend some time discussing the paper that you both co-authored along with several other individuals. Talk to me about, how the genesis of the paper. Ron?
Yeah, so it started over a year ago when the ABIM Foundation brought together a group of people to talk about trust and what we need to do to regain, restore, reinvigorate trust that people have in medicine. And as that group continued to discuss these really difficult topics, racism and bias and implicit bias, all these things, we said we have to do something that's going to make a statement, a collective statement that we have to act. And the first step in that is saying we need to commit to act. And so we begin to think about, if we put together this paper, bring together this group of experts, subject matter experts, industry experts, to say, let's put out a paper that's just the start, to say, here is a framework. Now let's go and do something about this. And one of the things that was in the background of this is, when we put this paper out there, a commitment to act, is more than just the usual blah, blah, blah.
So what is the usual blah, 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 Sachin?
Well, the usual blah, blah, blah is, the LinkedIn post, the tweet, the conference panel, the press release by the CEO after, some tragic event that says, we're going to make an X million dollar commitment, or we're going to start this institute, or we're going to hire this person, we're going to add this person to my leadership team, et cetera, et cetera, et cetera. And there is a degree of tokenism that takes place in this work. And it's a check the box type of activity in so many organizations and so many companies. I've sat in rooms at Fortune 50 companies where they say, oh, well, we hired so-and-so, we've solved the diversity problem. That's the exact opposite way to actually drive action. My personal belief is that this agenda needs to sit with the chief executive officer of every organization, and boards need to hold chief executive officers accountable, both through kind of continued employment, as well as through incentives for driving real meaningful progress on these goals. I had this incredible experience a couple of years ago that I think found its way into the paper, which is my board said, we're going to tie, 15% of your, annual executive compensation for you and all of your team members to whether you close a disparity in medication adherence among your African-American and Latinx members. And to my knowledge, it was the first time anything like that had ever been done. And, I would say 6 months into the year, there was a lot of talk, a lot of admiring the problem. And then there was the realization that we may not actually hit our incentive target, that our bonuses would be cut because we weren't actually making enough progress. And I will tell you, some amazing things started to happen. The creative juices, the problem solving started to actually take place. And, while we'd like to think that we don't necessarily need to tie financial incentives to, whether or not organizations are committed to these topics, it is also a measure of their true commitment, whether they actually put their money where their mouth is and actually tie progress on these issues to whether or not, people are achieving certain goals. And then by the end of the year, magically, we actually achieved our goals. We exceeded our goals in part because there was a high degree of board level scrutiny to whether we were going to achieve these aims or not. Because I think there was a degree of fatigue. There was a talk fatigue because the organization for years had talked about, oh, we care about minority communities. Well, what's our degree of penetration in minority communities? And what are our health outcomes among minority members and minority patients? And again, I look across the industry and I just see so much like fake commitment. I hate to call it that, but if somebody says, oh, I dedicated, if they're a $100 billion entity and they dedicate, $3 million to healthcare disparities, it's just not enough. And rather than celebrating it and tweeting about it and posting about it, we actually need to start calling it out and saying it's not enough. And so I think we have opportunities to really change the culture around this topic. And what I've learned through this engagement is that when you actually do set these goals, you can start to move the performance. And truly creative things start to happen within organizations when you do that.
What I'd like to do really quick, Nick, if you could show the picture of the folks that got together that were a part of the action group. Thank you. There you go. This is the Health Equity Action Group that came together post the forum and had several conversations on what does action look like. So thank you, Nick. You can take that down. And to you, Ron, what does action look like? So from Sachin, we heard, people will activate and will work in their own self-interest. So I love the, the bonus being tied to and the progress that's made when you are in that moment. What does action look like to you?
Yeah. So first I'll say Sachin just did an excellent job of walking through the paper. But what action looks like is what we're doing right now, to have these conversations. What actions looks like is at least 5 years ago, we couldn't use the word racism in major journals. In fact, I wrote an article that a major journal said we can't say that word, and other organizations that couldn't say the word racism. So that's an action. When they're saying we can say that word, we need to understand what this is and how it operates. When major journals are now saying we are committing to publish more about this, and guess what? We haven't in the past. That's progress that you can measure. There's progress that you can measure when you do have big payers committing to this, when you have other institutions saying we haven't done enough and we're committed to doing more. When you have CMS saying we're going to move ahead with regulatory language around building a culture of equity. And here's the things we're going to look at and quite frankly compel you to begin to do. When you go to the Joint Commission and say we have standards that will address these issues, but then elevate it to a national patient safety goal that goes into effect this year, those are firm actions that says to the universe, even if you're not Joint Commission accredited, it says to the whole world that we're committed. These are the actions that we're saying you take. And when you look at all of that, it starts with that first section in the paper that says leadership and governance has to commit to this. So those are distinct actions. These are conversations that we're having that we never had before. We can say, well, the Breonna Taylor and George Floyd were catalysts for some of this. COVID was a catalyst for some of this, but it's converged all of this activity. And is there pushback? Yes, there is. We currently have 8 states that suing CMS in Mississippi to say, you can't tell us to talk about being anti-racist. So there's going to be that resistance, but change always meets resistance. But what we are left with actions that are hopeful. And as I've always said, inaction is a violent act in and of itself. So there's a lot happening that we can measure in this work.
Yeah,
It's-
I
yeah.
want to just chime in on the paper point. In 2013, when I wrote about my experience with the racist patient, I had 2 major medical journals reject it, saying, this is not a topic that was worthy of their interest. And Annals of Internal Medicine, Christine Lane at the time, published it despite the fact the reviewers thought it was not worthy of interest. And what happened afterwards was, like, literally, I got hundreds of letters from minority physicians throughout the country saying thank you for kind of laying bare what's actually happening out there when we do have racist patients in clinical settings, and the experience that you had and the emotions that you felt. But otherwise, there were people who didn't want to hear about it. When it first happened in the hospital, there was no guidance, there was no support from HR, there was no support from my attending. My attending basically said, I'm sorry this happened to you, but, like, let's move on from it. Let's not, there's nothing really to do about it. So, again, I think what Ron's point is absolutely right. We have to create the space for the conversations. Now, I would say, I would push it a little farther, though. I think we've created a lot of space for conversations, but now we have to kind of make people uncomfortable. And I think one of the biggest problems we have is, I think we have a leadership crisis in American healthcare right now. We've trained a generation of people to think that uncomfortable conversations are somehow kind of anti-corporate, or kind of anti-company or anti-hospital. We need to kind of support the people driving the uncomfortable conversations, because in every meeting room in American medicine right now, there's that person in the room who's raising their hand, saying the uncomfortable truth that needs to be said. And then there's a whole group of people around them who are sitting silent, thinking, I'm glad he said that, but not doing anything to support him or her. And it can be on topics of race, but it can be on all kinds of other topics within healthcare. And, then we look at ourselves and we say, why is the system so messed up? Why isn't it getting better? And it's not getting better because I think we have a lack of courage. And if there's a group of people who should have more courage, it's us, because there is a labor shortage. We can all pick up and move across the street if we want to go work somewhere else. So I think we need to start kind of naming names and calling out the problems that we have, even if it makes us uncomfortable, even if it challenges the status quo. I think that's what we need more of than anything right now.
The thing that I would like to have those uncomfortable conversations, but I feel like the conversations are so polarized that we can't even have them. I was at a doctor's appointment today, as a matter of fact, and my physician basically said to me that it's poor, it's not race, it's socioeconomic, it's not racial. And I wasn't feeling great, so I really didn't want to go down that path in that conversation with him. But what do you say to people? I mean, I don't know that I don't mind having uncomfortable conversations, but the polarization seems to have stalled that opportunity. What do you take from that, Ron? How do you deal with critics that say, what, this is not real. Yeah. This is not a real issue.
Yeah. So that's where the commitment comes in. And that's where persistence comes in. When we have what's called a constancy of purpose on this work. And it's something I've always had in the face of rejection, in the face of resistance. So if we even just think about change itself, it's first met with shock, then it is met with anger. Then you hear those messages of resistance that you heard today. And I just say, people sink into this kind of valley of resistance before they begin to climb back up that mountain where they find the hope and the way forward. And that's what, when Sachin says courage, that's where that courage comes in. So we have to remain persistent and committed to this work. We use the data that is empirical data that as they say, you can have your own story, but you can't have your own facts. So when you look at that data, it tells a story. And those of us in this work continue to take that data in a way, qualitative and quantitative, and tell that story, to paint that picture, a picture of this is urgent. And we cannot grow weary. We cannot give up. We cannot be pushed back from it. We have to maintain that sense of commitment and courage that Sachin is talking about and keep moving it forward.
So we're 22 minutes into this conversation and we haven't used the word COVID yet. And I think COVID, certainly the pandemic created, if you could speak about a silver lining, it is that it has given this conversation a grounding that it didn't have 5 years ago. Can you talk a little bit about your experience with COVID and how you do believe that has shifted the conversation?
Well, I think we just saw the disproportionate impact that COVID had on communities of color. I mean, it was undeniable on some level, and even adjusted for income. And so when you kind of think about where that came from, some of it comes from, the mistrust that was seeded at the time of, the Tuskegee, studies. Some of it, I think, comes from the mistrust that was largely fomented by politicians who used kind of anti-science narratives to drive, perspectives into communities to, for kind of untoward purposes. But I would say the clarity that we got that these outcomes are worse in communities of color, in low-income communities, I think did give a clarion call to many of us that we need to do something differently. We need to start communicating differently. We need to start engaging differently. We need to start leveraging the institutions that people do trust when they don't trust the healthcare system, whether it's the church or community groups or foundations. And I think we started to learn how to do that. And I think we need to continue down that journey.
Yeah. If Nick could put up, if you would put up the framework of points made in the paper, that would be great. And Ron, why don't you start? Like, there might be a couple of points that are more salient to you than maybe Sachin, and then Sachin, any comments that you'd like to make off of that page? Nick? Great, thank you.
So thank you. And I'll go first to what we've already talked about just briefly, that we have to hold leadership and governance, which means the boards of directors, accountable. It's extremely important that we look at payment models and shift those payment models to address inequities in health and healthcare, because we know there's no new money. We know in terms of the money, we're in a zero-sum game, but if the projections are in a decade or more, we'll be spending $1 trillion a year on inequity. So we need to know where that money is headed. Medical education is critical. There are organizations now like the ACGME that took part in writing the paper that are already looking at undergraduate and graduate medical education around inequity, racism, structural institutional racism, and how it operates inside of a system. And then we talked about accountability, and it's key and crucial that we began to look at how we measure this over time, not just process, but outcome. If it's a structural measure, then fine. So for example, there's one CMS structural measure that says, what are you doing around maternal morbidity? And it's a yes or no. Are you engaged with it? Do you have a plan? Are you working with some other entity around decreasing maternal morbidity as a structural measure? And so then we like to think about access, but in this work we think about access in a different way. Yeah, I've had the Blue Cross Platinum card, so that gives me access. The question is, what happens to me when I get there? Just like what you talked about from your experience this morning. Mm-hmm. Am I going into a place where there's high quality care, where people care about me? Are they showing me empathy? Are you using logic in your decisions? Are you genuine and authentic? That is the foundation for trust. And if not, we continue to see what's been called a trust decay. So those are the things that are embedded in this paper. And it's saying act on all of those. Everything that's listed here is measurable if we commit to measuring.
Sachin?
Yeah, I mean, I would say I think embedded within the paper are some examples that are real, tangible, I think, kind of derived from real actions that organizations have taken. And, I think that every board, every like management team of every healthcare organization in the country should sit down with this paper and say, how does it apply to us? How are we going to make this actionable? How are we going to make this come to life? How are we going to animate it? Because, to your point, I think we can always get comfortable that we've done something when we've hired the person, when we've, checked the box around, some investment that we've made in response to events. I mean, I can't count the number of press releases that came out after George Floyd was murdered, where there's been really no follow-up action 2 or 3 years later, right? And so again, I think it's just creating the understanding that this is a theme that's going to be here to stay, that is central to our strategy. And I'm going to say something that's a little bit, this is not this kind of conversation, but I would say there's opportunities for healthcare businesses, nonprofits to win by focusing on these topics, because there's a lot of people who have unmet need, who haven't received service, who haven't been in the tent, who, when you bring them into the tent, are create opportunities to serve, but also opportunities to grow your organizations and drive the success of your organization. So I almost see health equity as good business strategy if you can kind of attract people who historically have been not willing to engage with the healthcare system to be part of your organizations, to receive care from you. There's a lot of growth there, and there's a lot of opportunity there. And so I've tried to sell this agenda both on moral grounds within my organization, but also on economic grounds, that there's opportunities for SCAN and all of its sub entities to actually, I think, succeed financially by actually focusing on being a better partner to communities of color, where there haven't been organizations that have previously leaned in before.
One of the things we talked about last week, we talked about allyship and what that looks like. So if you don't have buy-in at the top of the organization, it's not likely that the organization is going to embrace the conversation. I'd like to hear, Ron, from you on what allyship has looked like for you in your career.
Yeah, so it grows very thin, and it gets back to the word courage. There are folks that will go with me just so far, and then they're not there, and that's a lack of commitment. So as we get into this space, allyship becomes important. I coach people who are new in this space, are equity leaders, and one of the first questions I ask them: who's got your back? And literally, in some cases, those individuals will look over their shoulder on Zoom. No one's back there. And I say, well, okay, if you don't have top cover, who's your wing person? You got to have top cover. You got to have wing person. You have to be surrounded by like-minded people. And you think about change, what is that guiding coalition? So if I substitute the word ally for the guiding coalition, those folks are going to be with you. Then that's what we need to seek out. That's what collaboration is all about. That's what change is all about. That's what's moving off a melting iceberg is all about. Going out into that wilderness with people that are going to be there and are not going to tire, are going to be there to help you when you grow tired.
Sachin?
Yeah, I mean, I think for me, I would say it has been an equally lonely journey, rather. I would say there's a lot of people, if you're in a for-profit company, cash is king, quarterly earnings is king, and anything that seems like it's a distraction from achieving quarterly earnings is not respected or valued, even if there's stated commitments to this. And so I think there's a deliberate effort around really cultivating people whose intent is authentic. And I think that's actually the hardest part of this, to be honest with you, Pam, is there's a lot of people who have been trained now to say the right things. It's like people have been trained to say the right things. They know the right things to say in different settings. But the question is like, are they going to really be there when you need them to be there? Are they going to really step up when you need them to step up? I've had experiences where, kind of senior executives have talked about how there's no one in the marketplace to fill a position of color. That's why they hired their best friend. I've had people, who I've been in rooms where, people have mocked people for their accents, even when they were speaking totally clearly. And, people who are leading diversity initiatives for the company don't say anything when they mock the accents. And then you file a complaint with HR and nothing actually comes of it, because it's just part of the implicit code in lots of organizations that people are allowed to say what they want to say. They don't want to quiet conversations. And, and again, I just think we have an obligation to support each other. And so I always say that crazy person in the room that people usually ignore, that's the person you want to give a hug to visibly, because that's going to catalyze the movement. So even if you don't have allies, you can be somebody's ally, is what I like, how I like to think about it.
Right. So what I hear you saying, and it's, as you were saying, how do we hold people accountable? How do we make sure we're just not doing, the great window dressing? I mean, I'd like to think of the work that we're doing at ABIM as accountable to the larger community. How do we hold each other accountable? How do we insert ourselves in the conversation if we think that it's important to share that? How do we hold each other to account for the work that we're doing in this area?
Yeah, so I admire ABIF for this commitment, because I'm sure it's scary and I'm sure it's risky. And in many cases, I've been with organizational leaders who are afraid or who have said to me, this is too scary. So that's the first step. And then that's why I keep going back to the word commitment. So ABIMF committed to this work. That's the first step for all of us, to commit to this work. And the next is then, how do we prepare the way? So that's why I coach individuals that are new to this work. And sometimes that's uncomfortable truth, as Sachin talked about, to say, we need to have bench strength. We need to have a pipeline of people that are going to move this work forward and sustain this work over time. So working on developing those leaders becomes really important. Constantly self-reflecting. Could I have done different? What could I have said different? How can we strategize a different way with a different audience? So there are many tactics that we can begin to think about and structure to keep this work moving forward and sustain this work. But it's really important that we don't get lost in our own egos and sense of self-importance. And I ask people, are you in this because you want a rank or a title or some hierarchy or some power? Or are you committed to improving the lives of people who have been left out? And I'm constantly trying to read that. And I don't mind at all saying, I don't think you're in this for the right reasons. And if you're not, you're going to do more harm than good. So you maybe need to find something else to do. This is not for you. I don't mind saying that to people, because they're going to do harm. And that's where the term comes from, Sachin, about hustle. And I say, when I'm out doing this work, I'm looking for profits, not profiteers. I'm looking for someone that's going to write this down and have a vision. And they're going to go out there with urgency. And they're going to say, I know the seeds I plant, I might not be around to enjoy the shade of that tree, but I was there planting those seeds, and that tree is going to grow. And we're never going to go back to where we were.
Thank you, Ron. What I'd like to do now, Jamie, is I see there are some questions coming in. I'd like to give our guests an opportunity to ask Ron and Sachin some questions. Jamie?
Absolutely. So the first one is, how do we measure progress? So this was asked when Sachin, you were sharing what SCAN is doing by tying executive compensation to health equity goals. What else can organizations do to measure progress?
Yeah, I mean, the measurement is really looking at kind of key indicators that are core to your business, and actually tracking them and making them transparent, and talking about why they're improving or why they're not improving, and continuing to iterate on them. And I would say one of the things that I've seen organizations hide behind now for years is we don't have the data. We don't actually know how we're performing, on a by race basis. That's one way they hide. They say they don't have the data. The other way that they hide is they say, oh, well, we don't want to look at the data because if we uncover, disparities, it'll create legal risk for us. I've had that one happen to me too. And so I think what you have to do is kind of get beyond the legal risk conversation, and you have to get beyond the we don't have the data conversation, and just start with, making the data transparent and let the consequences be what they may be. And I think that I give my organization a lot of credit, people who came before me, because they actually collected the data, so we could look at it and we could say, okay, how do we do on medication adherence with our Black members? How do we do with our Latinx members? And how do we, how could we be better? So it starts with the transparency, and then it's motivating action, and I think consistent leadership messaging around it. And there's nothing more consistent than saying everyone's bonus at a manager level and above is tied to whether we achieve this goal or not. It's super clarifying for people that it's important to the organization. A press release is not clarifying. A new position appointment is not clarifying. An equity officer is not clarifying. I will tell you, tying everyone's compensation, including your own as the CEO, is super clarifying. And so that, to me, feels like the kind of moves that we need to see more of. I had the privilege, where I first met Daniel was when I was working in government, and the number of organizations that would kind of come in and they would be lobbying for something, and they would just kind of bring in there's some token initiative. And at first I would be like, oh, this is really cool. And then I would meet with them the next time and the next time, and they'd still be talking about their token initiative. And if you ask them whether that initiative actually affected all of their patients or just a small number of patients in some clinic, it was always the latter, never the former. And so again, I think it's that kind of scaling conversation that we need to be talking about, that kind of depth of commitment that we need to be talking about, because it's way too easy to do a little pilot project and say you care and call it a day. And that's literally what's happening in almost every healthcare organization in the country right now.
And another question from Jennifer, well, a comment and followed by a question. She said, with regard to centering equity in health services research, this is also a key finding in the work that Innovation and Value Initiative undertook regarding centering equity in health technology assessment. So her question is, how can material change in peer-reviewed journals, criteria, and research funding be drivers of change to achieve improvements in research and representation?
Ron, do you want to take that? Or
Yes, so
Sachin?
a challenging question, obviously with no easy answer. I think one is that the journals are now committed to accepting submissions on these topics and publishing them broadly. That's a measure. And I know that major journals are now committed to doing that. I know that NIH is looking at different ways to bring in disparity, equity related research that they have not done in the past. So that exists. I know that in the space of machine learning, robotics, and artificial intelligence, there are people working on how to make sure we don't design AI that worsens inequities and disparities. And the difference in all of this, increasingly in the conversation, is how we bring in the voice of people and communities in all of this. So there are multiple levels to work on in terms of research and knowledge sharing. And I'm not a researcher, but I would say there are some ways to look at research around improving the lives of people. And there are entities across the country that are now doing this. So they look at their population. They stratify by race, ethnicity, language, sexual orientation, gender identity. They look at where the disparities exist, and then they design changes that they can test and again measure, looking for better outcomes. And my hope in that is that the peer-reviewed journals will begin to publish more of that type of research.
Excellent.
Thank you. For either of you, what do you think is missing in conversations about health equity, and more specifically, who is missing in these conversations that you're having?
Well, some of it is nuance. I would say this conversation, and it's some of how, I think we end up alienating people inadvertently. I do think that there is nuance. I think when we speak in absolutes, what do they say in Star Wars? Only Siths speak in absolutes. That's that kind of dialogue. Even though I think Ron and I are both coming on very strongly in this conversation, I think knowing Ron a little bit, I think we're both also very capable of nuance and subtlety. kind of engaging the complexity of issues. And I think where organizations go wrong and start to begin to alienate people is they do an incomplete job of communicating the why, communicating the how, and balancing a DE&I initiative agenda with other kind of priorities. And so I think that we have an obligation to learn how to have these conversations in authentic and nuanced ways, and not just be almost bullies with an agenda, because there is a certain kind of moral grounding on which we stand. So I think that is one of the skills that we all have to kind of I think continue to develop, and it's something I've continued to work on, because you have to simultaneously demonstrate moral rectitude as well as sensitivity to bringing people along. And I think as impatient as Ron and I both are, there is that balancing act between being impatient as well as bringing people along, and knowing when to do which is, I think is a forever kind of evolution for me.
And Jamie, before we go to the next question, I just wanted to say, it's like trying to have this conversation and different and diverse audiences, like trying to modulate the way that you approach it, trying to outthink, the direction that you want to share in order to get what you need from the organization, I'm sure is, it's another challenge. You just can't say what you believe is true. You have to say it in a way that people can hear you. Right? So that's another piece of the challenge here. Jamie, do you have another question?
I do. Jeremiah asked, how do you collaborate with non-physicians in these settings to power action?
Yeah, for me, I go to them. I don't wait for them to come to me, right? We're in a system. And as we say, the system is perfectly designed to get the results that it's gotten. And I will say and challenge, my physician colleagues, looking at the world of patient safety. If we over medicalize this, we will end up back in the same place 10 years from now. So a collaborative means we have to be multidisciplinary. We have to be interdisciplinary. We have to reach out in a humble way. And that is servant leadership, to say, how can I serve you in this? How can we serve people and communities? Who are the experts in the community? So bringing in community advocates, community activists, all of those entities need to be around this table in the room, as we say in Hamilton, in the room where it happens, and looking around the room, which is what I do, and ask the question, who's not here? I ask a CEO, you say you're a servant to your community. How do you get to your community? And there are times when the CEO's eyes glaze over. Never been there, right? So reaching out and looking, Sasha, you talked about this, those voices that have been ignored for far too long. They're not going to be just the people with MD and DO behind their names. It takes all of us in this effort. It took a lot of us to get us here. It's going to take all of us to get us out of here to a better place. So we cannot silo this off from the rest of the community and people that we serve, and people that are in our workforce, because the people in our workforce live in the same communities.
Right. I think that's covered in the paper,
Yes.
Ron. And Sachin, anything you'd like to add?
Yeah, I mean, I'll just say, when I did end up publishing the piece on the racist patient, some of the feedback I got was from, non-clinical staff who said, this happens to me every single day. Like, it's exceptional to you because it happened to you as a physician, but a lot of the staff, were, minorities, did hear all kinds of commentary, never got that kind of protection. And so when I kind of got religion about that, one of the policies we've introduced and one of the kind of conversation points I have with our member services staff, which are largely kind of a lower paid staff that answer the phones for us at SCAN, is like, you never have to be subject to any abusive behavior or any racist tirades, and you should feel free to end the call and at any time you want if you feel uncomfortable. I think most people don't feel empowered to do that. I think in healthcare, we've kind of trained people with the patient is always right. That's one of the implicit assumptions around, the patient is always right. Well, sometimes if the patient is being abusive to staff, they're not always right. And we have to protect the workforce, and that includes the non-physician workforce.
Thank you. Great response about, the doctor is one thing, but what are the other folks around you? What are they experiencing, and how does that impact them? And how does that impact them in their communities as well? Jamie, you said that, I think we have a couple of other questions.
Yes, so during the conversation, Ellen commented that she was hearing visible acts of allyship as one measure of progress toward equity. And I received a direct message that asked if you could expand more on allyship and then give some examples of how you see that in your work every day.
Who do you want to message?
Ooh, that was Siri, I apologize.
Ron, why don't you take that first, and then we'll go to Sachin.
Yeah, so the question is, where do I see allies in this work? I think, is that what I'm hearing?
Yes.
Yeah, I think, again, I go back to word collaboration. In one collaborative, we spend a lot of time on how we develop allies. What does it mean to be an ally? That includes bystander training and a lot of techniques that you can use just educationally that you can then turn around and test those. And some of those tests come in real live situations inside of organizations. So developing that ally network, and a big part of an ally network is, again, going to the community and asking with humility, how can we best serve you? And the community will become your ally. What better ally can you have than a community that now trusts you because they believe that you're authentic, they believe that you are genuine, they believe that you are listening. So I would say start there. And again, I challenge boards and CEOs and C-suites, go and ask the community humbly, help us do this.
Help us do this work. Yes. Sachin?
Yeah, I mean, I think to build on Ron's comment about going to the community, one of the things I'm most proud of that we've done over the last couple of years is we launched an LGBTQ plus focused health plan for the older adult population. Something, first in our industry to do that. And I think the very signal of actually us doing that as an organization created an immediate community of people within our organization who had not even come forward before as being LGBTQ plus, that actually rallied to drive the success of the product. And we sold over 500 members in our first year, which was a great start. And I would say, when you start to make communities feel visible, when you start to take real actions in your business to align with people who have historically been disenfranchised, you elevate them, you elevate their ability to speak, you elevate their leadership, because they are now being seen and being heard in a way that they never have been before. And so again, I think it's commitments at that higher level will then naturally surface allies. So I think that there is some community building that arises from initiatives like launching a new product or introducing a new plan.
Jamie, I thought I saw another question come in. Am I correct on that?
There's one more. What innovative approaches are being developed to address inequities in low income and rural communities? And how can we scale up those models to reach more people? And then Sally commented that she's eager to learn from others about this work as well.
Yeah, first let me start by saying going out and looking to learn from others. That's going to be really important to do. But there are collaboratives around the country that have looked specifically at rural communities. And it could be rural, poor white communities. It could be rural, poor white elderly communities, because we get into ageism and povertyism and ruralism that creates inequities. And one of the things that these systems I work with are doing, they look at one of the most bluntest of measures. What is the life expectancy in those rural areas? And then you look at insurance rates, that's data. And then you can look at what is the situation around housing security, transportation insecurity, utilities insecurity. Is there ability to bring telehealth to rural and impoverished communities? Is there access to bandwidth? Where can you go for telecare services, whether that's video or audio services? So you look for those gaps in service. You look for, is there a pharmacy desert? Is there a food desert? And you can build, and these systems are doing this, and then build interventions to address those areas that are most acute. Start there. Get those early wins with the resources that you have, because we all have limited resources that you can measure, and then go out and seek allyship, seek additional support, seek others that will come and assist you in this work. So there are qualitative and quantitative ways, and people are doing this work already, both in urban areas as well as impoverished rural areas across the United States.
Thank you, Ron. Sachin, anything you'd like to add about rural?
Yeah, I think there's, the only thing I would add is I think there's a number of companies that are now kind of popping up that are focused on this issue of rural healthcare disparities. Main Street Health, Homeward is another one, or Homebound. I think it's Homeward. Those are just a couple of names that come to mind. But I think the issue is gaining more traction in the investor community and the business community. And I think there's a few entities that are popping up to serve the rural population better.
Excellent. So I just wanted to have, share, you mentioned Daniel Sachin, and I want to make sure that I introduce who Daniel is for the rest of the folks on the call today.
I just assumed Daniel was, known throughout the land.
Yeah, he is known throughout the land, but I just want to make sure he's known throughout this conversation. He's our Executive Vice President and COO for the American Board of Internal Medicine Foundation. He's been here doing good work for the better part of 22 years. And he is one of my allies as I joined the organization, and we work to keep momentum going in the organization. So I just wanted to take a moment to applaud Daniel and the work that he's done. I want to show, Ron shared a PowerPoint with us, and there was one particular page that kind of said to me, this feels very and looks very familiar. And I'm talking about the one, Nick, where there's two people standing on this. There you go. There's Sachin and Jane. They're sitting, Sachin and Ron sitting on this icicle, the wall of inequity. I want to thank both of you for your commitment to this work. It is not easy work. It is courageous work. And you talked a little bit, Ron, about, I'd like to hear from both of you as we close out today, at the end of the day, it's how you feel and how you could feel, and anyone in this work could feel that way. But at the end of the day, it's a conversation about who you serve. Right. And if we have like 5 minutes, actually we have like 3 minutes. So if we could I'd love to hear from you, Sachin and Ron. Who do you serve, and why are you engaged in this work?
Yeah, I would just say I feel like my mission is to try to make healthcare better. Where I'm at in my career and my life is I'm 20 years into it, and I feel like it's only getting worse, not better. And so I'm maybe narrowing my ambitions a little bit to focus on a few populations, a few groups of people, a few segments. And I think, we all want to go to the place where we're most needed or where our impact is going to be most valuable. And I think there's, not enough folks who are focused on, people whose healthcare experience has been bad, has been made worse by racism and inequities in society. And that's kind of how I think about my mission, my work going forward. So.
Thank you, Sachin. Ron?
Yeah, I serve people that historically have been devalued and dehumanized. I serve populations that have been left out and left behind. I serve populations that have not been given the opportunities or the resources needed to live the healthy lives that they want to live. So when I think about this, these are some of the groups, not all, that I commit to serve. And this picture there that I use is saying no matter what that is, no matter who that population is, they're not too heavy for us. So these groups are not too heavy for me. So I will continue to commit to serve them in these particular groups. All the work that I'm involved in focuses on these groups of people and communities that you see here. They're not too heavy.